Okay, well, we can start now. So the very first question is about clinical trial, and it is being asked like which phase of the clinical trial it correlates with the post marketing surveillance. So clinical trial and post marketing surveillance. Now, what do we mean by the word post marketing surveillance? Now, this word actually means that the drug is introduced into the market, and now we are going to do long term studies where we will be evaluating the side effects of the drug, the interactions of the drug with other drugs, or some idiosyncratic reactions. So it is a long term study, and this is actually the phase 4 of a clinical trial. Now let us take the different phases in short. Now phase 1 is actually about the safety of the drug which we are planning to introduce, right? So the very first thing is that whatever the drug we are planning to introduce should be safer to the humans. So safety is the concern, so it means it should be safer to humans. Clear? And therefore the drug is given to healthy volunteers under you can say ICU setup. So in rare case, if there is any reaction, the person can be managed timely. So this is given to healthy volunteers, non-patients. So the very first step is to assess the safety of the drug. Once we are sure that the drug is safer, then we go on to study the effectiveness of the drug, right? So in the second step, we go to study the effectiveness of the drug, and here we discuss about efficacy and other factors. So in phase 2 we discuss effectiveness of the drug. Now what we do in phase 3, obviously if we are introducing a new drug in the market, then there must be some drugs which are already there in the market. So what we have to do? We have to do comparison, that whatever the drug we are planning to introduce in the market, is it really superior to the already available options in the market? So we have to do therapeutic comparison, right? So this is phase 3. Now once these 3 phases are done, hello Siva, so then we will introduce the drug into the market. Clear? So introduce the drug into market. Clear? So once the 3 phases are done, then the drug is introduced into the market, and then in the phase 4 we do post marketing surveillance. And post marketing surveillance is a long term study. Clear? And here we want to study the side effects. Clear? So we want to study the side effects. We want to study the drug interactions. If we are giving this drug in consideration with other drug, what will be the interaction? And idiosyncratic reactions. Clear? So this is what we study in post marketing surveillance, which is actually the phase 4 of clinical trial. Clear? So which phase of clinical trial correlates with post marketing surveillance? It is phase 4, where we want to study the side effects, we want to study the drug interactions and some idiosyncratic reactions. Clear? So this is phase 4. So just to summarize, in phase 1 we look for the drug safety, that is non-therapeutic. Okay, so we just want to make sure that the drug is safer to the humans. In phase 2, we check effectiveness or efficacy, so that is therapeutic effectiveness. Then in stage 3, we compare the newly formulated drug with the already drugs in the market, that is therapeutic comparison or confirmation. And lastly, once we are satisfied in all the 3 phases, the drug is introduced into the market, and then after that the phase 4 will continue. So that is a long term study, right? So post marketing surveillance, phase 4. Now another question is about potency, and this is one topic on which we have questions many times. It is a straight away theoretical fact based question, sometimes it is an image based questions checking the concept whether you know about potency or not. Now to check potency, now before that we should know what is potency. Potency is actually the amount of drug. Clear? So this is the amount of drug which is needed to produce a desired effect. Clear? So this is potency. How much amount of the drug is needed to produce certain desired response. So potency is about amount of drug. Okay. Now there is one more term, and that is efficacy. So there is one more term, that is efficacy. Now what is efficacy? Efficacy is the maximum effect of a drug. Clear? So maximum effect of a drug which is produced by given amount of drug. Clear? So efficacy is the maximum effect produced by a given amount of drug. So this is efficacy. Efficacy is effect. Okay, you can remember like this: efficacy is effect and potency is the amount. Clear? So please remember these two very important concept. Many times we have a question from this. So both of these, they can be studied from the dose response curve. Clear? So potency and efficacy both can be studied from dose response curve, which is written as DRC in short. Okay, so this is DRC, dose response curve. Obviously dose is actually the amount, right? So amount is what? Dose. And response is actually effect. Okay, so response is actually effect. So the term effect we are using here, this is actually response, and amount what we are discussing here, this is actually the dose. Clear? So dose and response curve. Clear? So we are using dose and response in both the entities, and therefore yes, Siva Kumar Naik Mude, absolutely right. A is the answer here, right? So now potency is the amount of drug needed to produce certain response, and efficacy is the maximum effect which a given amount of drug will produce. Now let us study this with the help of a graph, and I think this will make your concept much more clearer. So suppose if we are studying two drugs, say drug A and B. Okay, let us take two drugs, drug A and B. Now when we, so this is drug A, this is drug B, and this is obviously the effect, right? So this is the effect, or what you call response. And on this axis we will discuss the dose. So this is the dose. Clear? So response above, dose here. So this is dose A, this is dose B. Now what we can see, so again what we will write? We will write dose, and we are actually evaluating the response curve. So we will write dose and response. Now what we can discuss about A and B? The dose of A is less than dose of B, right? So this is less, this is more, because we need more dose of drug B as compared to the dose of drug A. But what about the response? Response is almost same. So response is same for both the drugs. So here what we can say, that drug A is, yes, very good Shiva, very good. So drug A is more potent than drug B. So this is in terms of potency. So in potency what we need to check? We need to check the dose of the drug which is needed to produce the effect. So here both drug A, drug B, they are producing same amount of effect. So the response is same, but the amount of dose of drug A is far less than the dose of the drug B which is needed to produce this response. So this is potency. Effect will be same, the response will be same, but the drug which will be required in less amount will be termed more potent than the drug which is required in high dose, right? So less dose more potent, high dose less potent. Okay, so just remember it like so. Less dose means more potent, and the only condition is that the effect has to be same of all those drugs, then only you can comment on potency, right? So if the effect is same, the drug which is needed in lesser amount to bring about that effect is known as more potent. So here we will say that A is more potent than drug B because we need very less amount of drug A as compared to the drug B, right? So this is the concept of potency, amount of drug needed to produce a certain desired response. Okay, so this is potency. Now next question is about bioavailability, and it is being said that there is a drug which has 30% bioavailability. Now what does this mean? Bioavailability. Clear? So bioavailability. Now this is the amount of the drug which is finally there in the blood column and is available to produce the effects of the drug, right? So that is known as bioavailability. So here you need to suppose if we are taking a drug by oral route, suppose if you are giving the drug by oral route, it will go to GIT, right? From GIT it will be absorbed, and from after absorption it will go to liver. Now we know that liver is the site of metabolism, so some amount of drug will be metabolized here, right? And the remaining drug, right? So the remaining drug will go into circulation. Clear? So the remaining drug will go into circulation, and this drug which is going into circulation and which is available to produce effects will be it will be known as the bioavailability of that drug. So suppose now if we take this condition, the bioavailability is 30%. So it means only 30% of the drug is going into circulation to produce the effect. So bioavailability is 30%. Then what does it means? The 70% is metabolized, right? So this is the concept of bioavailability, and the metabolism which is occurring here in the liver, this is known as first pass metabolism. Clear? So this is known as first pass metabolism. Fine. So this is how you need to remember few terms: bioavailability and first pass metabolism, and this is especially with respect to oral route, right? So if we say that 30% of the drug is available to bring out the response, so 30% of the drug reaches the systemic circulation in unchanged form, right? So this is in systemic circulation. Clear? So this is the concept of first pass metabolism and bioavailability. Bioavailability is that form of drug which will reach the systemic circulation and that is available to bring about the drug effects. Clear? So if 30% is reaching into systemic circulation, we will say that the bioavailability is 30%. It means 70% is metabolized. Okay? Okay, great. Let's go ahead. So this is the concept which I was discussing. So this is of course GIT here. Okay, so we have taken the drug by oral route. It will go to the liver. Here some amount of drug will be metabolized, say 70% is metabolized, and then the remaining 30% will go into the systemic circulation, and that will be known as the bioavailability. Okay, so I think you won't forget it now. Chalo. Next question. During surgery, a patient was given nicotinic receptor acting competitive neuromuscular blocker drug. Now, which drug is needed to reverse the end of this drug at the end of operation? So what is actually being given here? This is competitive neuromuscular blocker drug. So this is competitive neuromuscular skeletal relaxant, you can say. So skeletal muscle relaxant, right? And as the name suggests, they are acting on the neuromuscular junction, and these are also known as non-depolarizing. Clear? So when we give these agent, obviously they will help us during the operative process, but once the surgery is over, we have to reverse the effect of these agents. So to reverse, we need to give neostigmine. Okay, we give neostigmine actually, because what neostigmine is doing, it is inhibiting acetylcholinesterase enzyme. So it is inhibiting acetylcholinesterase enzyme, and this enzyme is actually causing breakdown of acetylcholine. So if you inhibit this enzyme, obviously there will be high level of acetylcholine at the neuromuscular junction, and therefore there will be overcoming of the effect of these competitive neuromuscular muscle relaxants. Okay, so this is how we reverse the action of competitive neuromuscular activity by giving neostigmine, which will inhibit acetylcholinesterase enzyme, and this is one enzyme which is actually needed for breakdown of acetylcholine. So if we inhibit this enzyme, obviously we'll be inhibiting breakdown of acetylcholine, and the level of acetylcholine will increase at the synapse, right? And this will reverse the blockade. Clear? So this is the concept here. So neostigmine for reversal of competitive neuromuscular blockade, right? So here we can see the neostigmine, it is inhibiting acetylcholinesterase, which actually brings about destruction or damage to or breakdown of acetylcholine. Now next question is about first order or linear kinetics. So all of the following drug follows first order or linear kinetics except. Now for this you need to understand what is first order kinetics. Now remember one alphabet, that is F. So F stands for first order kinetics. Clear? And here you can remember a fixed fraction. Okay, so a fixed fraction is eliminated. Clear? So fixed fraction of drug, or you can say a constant fraction of the drug, is eliminated, right? So F for first and F for fraction. So remember that way. Okay, so now let us take the graph first. Now this is the first order kinetics or first order elimination of the drug, and here a constant fraction or a constant proportion of the drug is eliminated per unit of time. So if we write the definition, a constant fraction of the drug, right? So a constant fraction of the drug is eliminated. Clear? So a constant fraction of the drug is eliminated, and therefore the rate of elimination of the drug is proportional to the plasma concentration of the drug, right? So this is proportional to the plasma concentration of the drug. As a result of this, clearance is constant, and also the plasma half-life is constant, right? So this is all about first order kinetics. So this is about first order kinetics, and this is shown by majority of the drugs. So majority of the drugs, they follow first order kinetics, where a constant fraction, so F, so remember F here and F here, so constant fraction of the drug is eliminated, therefore the rate of elimination is proportional to the plasma concentration of the drug, then clearance is constant, and plasma half-life is also constant. So this is plasma half-life. Clear? So please remember this for first order kinetics, and fraction can be say 20%, 30%. So this is first order kinetics. Now there are certain drugs which follow zero order kinetics, and there is a mnemonic for that. So you can remember it by the mnemonic like 0. Clear? You can remember 0 watt power, like so a bulb of 0 watt power. So 0 is of course zero order kinetics here, right? So this is 0 order kinetics. Fine. Then what? W is for warfarin, A for alcohol, aspirin, T for theophylline or tolbutamide, and P is for actually anticonvulsant phenytoin. Clear? So these are some drugs which shows zero order kinetics. So most of the time actually the question is about zero order kinetics. So remember this mnemonic and this will really help you in exam. So if we go to the question proper, the answer will come out to be phenytoin, because phenytoin is showing zero order kinetics. Clear? So remember phenytoin for zero order kinetics, although we have discussed about first order kinetics. Next question. Which of the following drugs requires therapeutic drug monitoring and except? Yes, Siva, phenytoin is the answer to that question. Now, all of the following drug requires therapeutic drug monitoring except. Now here you need to understand the concept of therapeutic drug monitoring, right? Monitoring means we have to measure the blood levels, clear, and obviously of a drug. So we have to measure the blood levels and we have to make sure that the level of that drug remains within a particular range, right? So we have to ensure the drug values in a particular range, okay, in a particular range. And this particular range is actually known as therapeutic window phenomena. Now this question is about except. So we have to rule out the drug for which we don't do therapeutic drug monitoring. Now suppose if this is, say, the safe level of the drug, if the levels are below this, there will be less effect, clear? And if the levels are above this, there will be toxicity. So that's why we want to make sure that the levels of the drug are always within this range. So this monitoring is known as therapeutic drug monitoring. So there are certain drugs, if the blood levels are low, there will be less effect. If the blood levels are more, there will be toxicity. So we have to make sure that the drug values in the blood is within that range. Yes, Siva, very good. So the answer is ciprofloxacin, because for this we don't do any therapeutic drug monitoring. We require monitoring for lithium, we require monitoring for digoxin, and we require monitoring for theophylline as well. So the answer will be ciprofloxacin, because for that we don't require any monitoring at all. So therapeutic drug monitoring, remember few good examples like lithium, digoxin, theophylline, clear? So if we see here, this is the safer blood range in which the drug will produce good effects, right? So this is the therapeutic range. If the values are below this, less effect, or you can say there is no benefit of giving the drug. And if the values crosses this, there will be toxic effects. Patient will have complications, right? So this is if the values are more, this is if the values are less. So we have to maintain the blood level within a particular plasma range, right? So that is known as therapeutic window phenomena. So therapeutic window phenomena means the optimal effect are exerted over a yes, Siva, TCA, methotrexate, cyclosporin, yes, many, the list is very long, yes, very good. So therapeutic window means we have to maintain the drug value in the plasma within a specific range. If the value is less, no effect or less effect. If the value is high, side effect or toxic effects. Now next question. A 70-year-old male has benign prostatic hypertrophy, BPH. Now which drug will help you in controlling the symptoms of urinary urgency. So for benign prostatic hypertrophy, which drug we give? I think most of you must be knowing. For benign prostatic hypertrophy, we use drug therapy that includes the, say, prazosin group of drug. Clear? So we used prazosin. Now what is the mechanism of action? Yes, tamsulosin. So what is the mechanism of action of these drugs? Actually, we know that there is urinary sphincters, and these are closed by alpha 1 receptors. So alpha 1 adrenergic receptors. Clear? So if we block these receptors, obviously the urinary sphincters will dilate or will open up. So that will just help the patient in getting rid of the symptoms. So what we do, we use alpha 1 adrenergic blockers. Okay, so since they relax smooth muscle, so the overall property is it can be given, but we are talking in terms of the adrenergic receptors. Yes, 5-alpha reductase inhibitors can be given, no problem, right? So here, now this is in terms of adrenergic receptors. So we will prefer blocker of alpha 1 adrenergic receptors, right? So here we can use prazosin, terazosin, doxazosin. So all these agents, they will relax the urinary sphincter, right? The internal urinary sphincter, and then they will promote urine outflow, right? So this is the mechanism of action of these prazosin group of drugs. They are alpha 1 adrenergic blockers, right? So these are blockers of alpha 1 adrenergic receptors, because alpha 1 adrenergic receptors are usually smooth muscle constrictors. So they close the internal urethral sphincter, thereby holding the urine. So if we can block those receptors, there will be relaxation of that internal urinary sphincter and there will be outflow of urine, right? So this is the mechanism of action as far as the adrenergic receptors are concerned. Now, which one is true regarding the mechanism of action of labetalol? So what is true regarding mechanism of action of labetalol? I think most of you must have read about labetalol, that it is used an anti-hypertensive agent, right? So the property of labetalol, now if we talk in terms of labetalol, it is actually dual receptor blockers, right? So if we talk about mechanism, it acts on alpha 1 adrenergic, and it also acts on the beta adrenergic. Clear? So alpha 1 is specific and non-beta adrenergic. So it is acting on dual receptors. So the best answer is it blocks both, right? So both beta adrenergic and alpha 1 adrenergic receptors. So it is blocking both alpha 1 right? So it is blocking this and it is also blocking this. So labetalol is alpha 1 receptor blocker. It is also non-specific beta receptor blocker, and alpha 1 receptor blocker, we just discussed that there is vasodilation, smooth muscle relaxation, so there is fall in peripheral resistance. On the other hand, by inhibiting the beta receptors, it diminishes the sympathetic activity over the heart, so protects the heart from reflex sympathetic drive, and collectively the effect is fall in blood pressure. And that's why I said labetalol is used as an anti-hypertensive agent, means it lowers blood pressure. So it has a dual action, alpha 1 blocker, non-specific beta blocker. Okay, so please remember labetalol, alpha 1 blocker, beta blocker. Chalo, next question. Which is an anti-glaucoma drug? Means we are giving it for glaucoma, and it is an alpha 2 adrenergic agonist. Yes, Siva, it is used in pregnancy. Yes, very good. Okay, so we can use alpha methyl dopa, we can use labetalol in pregnancy for hypertension. Yes, right. So which of the following anti-glaucoma drug is alpha 2 adrenergic agonist? Now, what do you mean by the word agonist? Agonist means it will promote the activity of the receptor. So the effect is in line with the activity of the receptor. So it is alpha 2 adrenergic agonist. So which alpha 2 adrenergic agonist can be used as anti-glaucoma drug? The answer is apraclonidine. Okay, so apraclonidine is an alpha 2 adrenergic agonist, and it is helpful in glaucoma patient because it promotes uveoscleral outflow of aqueous, and it also decreases the aqueous production from the ciliary body. So what alpha 2 adrenergic agonists are doing? They are acting at two places. One, they are reducing aqueous production, and number two, they are increasing uveoscleral outflow. So that is how it is helping in glaucoma, right? So apraclonidine or brimonidine, both are alpha 2 adrenergic agonist, helpful in glaucoma patient, and they decrease aqueous humor production. Clear? So they decrease aqueous humor production, and moreover they increase uveoscleral outflow of aqueous. Clear? So acting on two fronts, because we know that the pathology in glaucoma is what? There is impaired drainage of aqueous humor in open angle, and if there is narrowing of the angle of anterior chamber, there is no enough space for the aqueous humor to reach up to the trabecular meshwork. So overall it acts on two fronts, reduces the aqueous humor production and also promotes outflow through the uveoscleral tract. Clear? So apraclonidine and brimonidine, alpha 2 adrenergic agonist. Please remember agonist. This is important. Now next question. Now this is again a little tough question, and many times we have question like this. They will give you certain combination of drug, there will be some side effect, and then they will ask you which particular drug is responsible for this particular side effect. Like in this case, a patient is taking indanavir, which is a protease inhibitor anti-HIV drug, lamivudine, and he is also taking ketoconazole. So he's taking 3 drugs simultaneously: indinavir, lamivudine, and ketoconazole. During the course of the treatment, he developed renal stones, that is nephrolithiasis, and he also has hyperbilirubinemia. So renal stones, clear? This is nephro and this is lithiasis. Also, he is having increased bilirubin in blood, that is hyperbilirubinemia. Now, out of these 3 drugs, we have to answer which drug is responsible for this type of complication. So I think this is little difficult from your point, but this is indinavir. So indinavir, an anti-HIV drug, protease inhibitor class. It can cause renal stones and it can also cause hyperbilirubinemia. So this table might help you. So this is indinavir, which can cause nephrolithiasis and hyperbilirubinemia. Okay, so slightly tough question. Now next question. A patient of hypertension was taking some anti-hypertensive drug. So there is a known case of hypertension. He is taking some anti-hypertensive drug, but there is a complication, and that is cough. So which anti-hypertensive drug can produce dry cough as a complication? So any idea? So if we write it like this, anti-hypertensive leading to dry cough. So any drug which can cause, very good Siva, very good. This is ACE inhibitors, very good. So this is ACE inhibitors and all your pill kind of drugs, right? So captopril, enalapril, lisinopril, so all pill kind of drugs, so which ends with the word pril, right? So they can cause dry cough. Very good Siva, very good. Now next question. Preferred drug for closure of patent ductus arteriosus in a preterm baby. So a preterm baby is born and there is patent ductus arteriosus. Very good Siva, very good Dr. Poo 14, very good. The agent of choice for closure of patent ductus arteriosus is endomethacin, although we can also try mefenamic acid, but drug of choice is endomethacin. Very good, both of you, wonderful. So and now we know what is a ductus arteriosus. In fetal life, since there is no respiratory physiology and moreover the oxygenated blood is coming from the mother, so there is no need of sending the blood from the right ventricle through the pulmonary trunk to the lungs. So what happens, the blood bypasses from the pulmonary trunk directly into the aorta. But this is fetal physiology. Once the baby is born, there is no source of oxygen blood from the mother side. There is respiratory physiology as well, so the blood has to go to the pulmonary circulation through the right ventricle and the pulmonary trunk, and therefore that shunt has to close. But what happens in certain circumstances, that shunt remains open. So what will happen, since the aorta is a high pressure zone, so the blood will flow from the aorta into the pulmonary trunk. So this is a kind of, you say, left to right shunt, right? So patent ductus arteriosus, it is a left to right shunt initially, clear, and we need to close it at the earliest, otherwise that will act as a shunt. Okay, so we need to give endomethacin. Now, which of the anti-asthmatic, if used in emergency, does not act by causing bronchodilation, means it does not dilate the bronchus. So which of the following anti-asthmatic drugs do not have a do not have a smooth muscle dilatory action? So out of the four, so here, because in asthma what we know that there is airway narrowing, clear? So there is airway narrowing. So obviously we try to do bronchodilation, clear? So see here hydrocortisone, it is a steroid, clear, and it has no effect over smooth muscles. It will not cause any dilatation or anything because it is having anti-inflammatory properties, right? So it is having anti-inflammatory properties, and therefore it will reduce the inflammation which is occurring in the airway. Yes, Dr. Poo14, absolutely right. So this is hydrocortisone. Now coming to ipratropium bromide, it is anticholinergic. So in one way it is bronchodilatory. So if we discuss the bronchodilators in pharmacology of asthma, we have two broad groups. Either we can take sympathomimetics or we can take anticholinergics, right? So one group is anticholinergics. So we just want to oppose the effect of acetylcholine, and another is obviously beta 2 sympathomimetics, clear? So we are increasing the action of beta 2 adrenergic receptors, which are actually meant for smooth muscle dilatation, relaxation, that is bronchodilation. So either we will go and we will oppose the cholinergic activity, or we will promote the beta 2 adrenergic activity. Okay, so we have two broad classes: beta 2 sympathomimetics, which includes salbutamol, terbutaline, bambuterol, salmeterol, or formoterol. In anticholinergics, there is ipratropium or there is tiotropium. Then there is another class, that is methylxanthines, which includes theophylline, aminophylline, right? So theophylline, aminophylline, and doxyphylline, importantly. So these are bronchodilators. There is no mention of steroids, there is no mention of cromolyn sodium or montelukast. Okay, chalo. So please remember this. Now next question: a known case of chronic asthma is on theophylline. Now concomitant use of which antibiotic will demand increase in the dose of theophylline? So suppose if we are giving theophylline, if we give any other antibiotic, we have to increase the dose of theophylline because this drug is increasing the metabolism of theophylline. Therefore, the effectiveness of theophylline is being reduced. Now try to understand what I want to say. One antibiotic which is increasing the metabolism of any other drug which is simultaneously given. So what is the name of this kind of antibiotic which is increasing the metabolism of any other simultaneously given drug? These are known as microsomal enzyme inducers. Clear? So this is microsomal enzyme inducer. Now, when I say microsomal enzyme inducer, one example should click in your mind, and that is nothing except rifampicin. So rifampicin is a microsomal enzyme inducer drug. If you give it with any other drug simultaneously, it will increase the metabolism of that drug, and therefore the effectiveness of the drug will fall, and now you have to increase the dose of theophylline. Okay. Yes, the list is very long for microsomal enzyme inducers, but I am more specifically in discussing rifampicin because it has been asked many number of times. Okay, so this concept is microsomal enzyme inducers. And with respect to theophylline, there are many other drugs which can cause fall in the level of theophylline. So decreased levels of theophylline, it can be seen if we give any of these drugs simultaneously, and especially I am interested in answering rifampicin. Okay, so rifampicin is very important here, although if you can just mug up the entire chart, nothing better than that, right? So if you give any of the drug, you have to increase the dose of theophylline, otherwise there will be no effect of theophylline because metabolism is increased. Then next question, a female patient was having pain in her right great toe, and this was associated with swelling, redness. She was treated with a proper drug therapy, but her uric acid remained elevated. Now, which drug can be given for fast elimination of uric acid from the body? So I think pain, swelling, redness in the region of great toe, this itself is this itself is talking about the diagnosis. The diagnosis is obviously, yes, anyone, what can be the diagnosis here? Pain, swelling, deformity, pain, swelling, redness, or features of inflammation in the great toe. This is obviously gout. Okay, and gout is what? Increased uric acid. Fine, this is one thing. Now she is already treated with some proper drug therapy, but uric acid is still elevated. Now, yes, Siva, absolutely right. The diagnosis is gout. Now, what actually we want to do? We want to do fast elimination of uric acid. Now the question is about fast elimination of uric acid from the body, and the question is not asking anything about reducing the formation of uric acid. So this is like a point which means that we need to give a uricosuric drug. We have to give a drug which will promote excretion of uric acid from the body. So the class of drug which we are going to give here is uricosuric, and uricosuric drug is probenecid. Clear? So this is how you will get your answer, probenecid, because we want to eliminate the drug quickly from the body, so we need to give uricosuric. Suppose if the question was about if you want to reduce the formation of uric acid, then obviously you could have gone for allopurinol, which is a inhibitor of xanthine oxidase, right? So depending on the specific statements in the question stem, the answer will be probenecid. So this is This will promote uric acid excretion. Clear? So this will promote uric acid excretion. So that's why the answer is probenecid and not allopurinol. Clear? Now next question, which is a monoclonal antibody used in cancer chemotherapy? So monoclonal antibody used in cancer chemotherapy. Yes, anyone? So cancer chemotherapy, and here I am asking about, very good Dr. Poo 14, yes, so I am asking about monoclonal antibody, right? So I am asking about monoclonal antibody, right? So now the answer is there in the question itself, MAB. So the moment you have this word MAB, monoclonal antibody, yes Siva Kumar, very good, MABs. So the moment you have this word MABs, it itself suggests that we are discussing monoclonal antibody. Okay, so MAB. So any drug which ends with MAB is a monoclonal antibody. So here we can see this drug is ending with MAB, so this is monoclonal antibody. Now this she word here, this is rituximab, so this she word is also having a meaning here. Now she means chimeric. So she means chimeric, and this is actually mixing up of the mouse and human, right? So if we take the nomenclature of monoclonal antibodies, which is very interesting. So now here MAB. So I think MAB word is clear to all. MAB, right? So MAB means monoclonal antibody. Now suppose we are discussing about this word rituximab, right? So the moment you have this word cimab, it's actually chimeric, and chimeric means there is a cross between the human and the mouse. So this is shimab or chimeric, which is a cross. Suppose if you have the word, if you have a drug which is ending with omab, then it means it is derived from mouse. If the drug is ending with umab, then it is humanized, and if it is mubab, you can say it is fully human. So you, depending on the terminology, shimab or umab, again umab, so you can understand like what is the origin of this monoclonal antibody. Okay, so shimab is chimeric and umab is humanized, right? So this is cetuximab, trastuzumab, right? So that way you can understand the nomenclature, which is very interesting nomenclature here. Okay, and anyway, rituximab, it is used for lymphoma. Now next question, a patient presented with complaints of morning stiffness of joints, and the treating doctor planned to start DMARD, that is disease modifying agents in rheumatoid disease. Which of the agent requires fundus examination and regular monitoring of visual acuity, right? So if you can just add the question number in front of the answer option, I think it will be very easy for me to understand, like you are answering which question, right? Because D was the answer to previous question, so at times it confuses me actually, right? So morning stiffness, especially of small joints of hand, particularly in a female, in a young female, you can say. This goes in favor of the diagnosis of rheumatoid arthritis. Clear? So this goes in the favor of the diagnosis of rheumatoid arthritis. And now, which disease modifying agent in rheumatoid disease can cause visual complication? This is hydroxychloroquine. Okay, so it can cause bull's eye retinopathy. Clear? So it can cause bull's eye retinopathy. So please remember this. So the drug which requires supervision in terms of visual complications is hydroxychloroquine, which is also written as HCQ. So bull's eye retinopathy. Okay. Chalo, next question. A known case of hypertension presented with complaints of palpitations and shortness of breath, and when we checked the blood pressure, it was 220 systolic and 140 diastolic. Now obviously the blood pressure is very high, so we need to reduce the blood pressure. But out of the following four options, which is of no use or which is not indicated here in managing the blood pressure? So the blood pressure is obviously high, 220/140. So obviously this is a case of hypertensive crisis, and the management is to reduce blood pressure. Very good, Dr. Poo. Very good, Dr. Siva. There is no need to give intravenous mannitol because this is principally used to reduce intracranial tension or intraocular pressure in case of glaucoma. So there is no mention of mannitol in case of hypertension or in case of reduction of blood pressure in case of hypertensive crisis, right? So IV mannitol is not indicated as such in hypertensive crisis where the BP is extremely high, right? So hypertensive crisis, we have two classes. Either it can be a hypertensive emergency where there is damage to the target organs. In urgency, there is no damage to the target organs, right? Okay, so moving forward to next question. A case of epilepsy was started on Lamotrigine, right? So a case of epilepsy was started on Lamotrigine and the dose was 50 milligram once a day. And what we did, the dose of the drug is gradually increased every 2 weeks, and then we reach the final dose of 200 milligram per day. Now why we are taking this kind of approach? Because what we are doing, suppose the final dose what we need is 200 milligram per day, but we are not starting like this. We are not giving this straightforward. What we are doing, initially we are giving 50 milligram per day, then we made it to say 100 milligram per day, then say 150 milligram per day, and then finally we reached to this level. So we took almost say 3 weeks to reach up to the dose which we want to have for appropriate effect. Now this is needed to prevent development of skin rashes, right? So this is how the Lamotrigine should be started in a patient. Don't start with the actual dose. In fact, start with a smaller dose and gradually increased it over a period of 3 to 4 weeks to the final desirable dose, right? So this is especially to prevent the complication, that is skin rash. So please remember it for Lamotrigine. Now, drug which inhibits conversion of angiotensinogen to angiotensin 1. So angiotensinogen, right, and this is converted into angiotensin 1. Now first of all you need to know which hormone act here. So this conversion is brought about by renin. Then angiotensin 1 is also inactive. It is finally converted into angiotensin 2, and this conversion is brought about by ACE, angiotensin converting enzyme. And then this angiotensin is the main one which can cause release of aldosterone from adrenal cortex, and it can also increase peripheral vascular resistance, and this will finally increase the blood pressure. So this is all the renin angiotensin aldosterone system, clear? And this tries to increase the blood pressure. So which drug is blocking renin, or which is inhibiting the conversion of angiotensinogen to angiotensin 1? And yes, the answer is aliskiren. Very good, Varsha. Okay, so this is aliskiren. Very good, Siva. So this is aliskiren here. Okay, so this is aliskiren. Fine. And I think for ACE, everyone knows this is ACE inhibitors, which are the prill drugs, enalapril, captopril. So captopril is ACE inhibitor, not renin inhibitor. For renin, this is aliskiren. Clear? So here you can see angiotensin to angiotensin 1 to angiotensin 2 and respective enzymes. And here angiotensin receptor blockers are the losartans, that is the sartans. Okay, so these are sartan, the angiotensin receptor blocker. Fine. So the sartans. Chalo, next question. A patient has shooting pain on touching the face or chewing, speaking, or brushing the teeth. Now what is this condition? Shooting pain on chewing. So this shooting pain on face, actually, on chewing, speaking, or brushing the teeth. Now what is this condition actually? So this condition is actually, yes, very good, Dr. Varsha, Dr. Poo, absolutely right. So this condition is actually trigeminal neuralgia. Okay, so this is trigeminal neuralgia, and yes, for trigeminal neuralgia we need to give carbamazepine. Okay, so there is paresthesia in the distribution of the trigeminal nerve. Very good, Siva, very good. Now drug of choice for bipolar disorder. Now when I say bipolar, so bipolar disorder, actually it includes depression and it includes mania. So in such a case we need to give a mood stabilizer, right? So we need to give a mood stabilizer, and that is, yes, everyone is absolutely right, that is lithium. So Siva, Dr. Poo, Varsha, everyone is right. So we need to give lithium as a mood stabilizer for bipolar disorders. Now an example of oral direct thrombin inhibitor. So direct thrombin inhibitor. Now this thrombin is actually needed for conversion of fibrinogen to fibrin, and that will lead to coagulation, right? So if we are stopping that final step, so fibrinogen to fibrin, and this is obviously, and this fibrin is actually the clot, clear? So if we are just inhibiting this thrombin, it means we are using it as a anticoagulant. So you can say oral anticoagulant. So this is actually dabigatran etaxylate, right? So oral direct thrombin inhibitor is dabigatran. Clear? Aspirin has nothing to do with coagulation pathway here. So this is how it produces anticoagulant effect, right? So this is dabigatran etaxylate, and for heparin, I think most of you must be knowing that it is a inhibitor of factor 10. So if we just see here some oral drugs, clear? Because we know that heparin we have to give as a subcutaneous injection. So now these are oral drugs. So the one which is inhibiting thrombin, because thrombin is needed for this final effect where fibrinogen is converted into fibrin clot, and this thrombin is inhibited by dabigatran etaxylate. So oral direct thrombin inhibitor. There are some oral direct factor 10A inhibitor, clear? So these are oral direct, clear? And here we can also write oral direct thrombin inhibitor. So these are two classes, please remember them. So for oral direct thrombin inhibitor, just like this, we can remember dabigatran. So this is dabigatran acting here. And for factor 10A oral direct inhibitors, you can remember apixaban or batrixaban, edoxaban or rivaroxaban, right? So just remember these, and the answer here is dabigatran etaxylate. Now, which of the following diuretic acts on the loop of Henle? And therefore, this diuretic is also known as loop diuretic because they act on the loop of Henle. Yes? And Varsha, absolutely right. The answer is furosemide. So furosemide, loop diuretic. Yes, very good Siva, very good Varsha. So this is furosemide. And if we just take a look, now this acetazolamide is a carbonic anhydrase inhibitor. Now if we just have a look, like this acts on PCT. Mannitol also acts on PCT, and thiazides, they act on DCT. So these are the different sites of action. Thiazides on distal convoluted tubule, furosemide on loop of Henle, mannitol and acetazolamide on PCT. Clear? So this is how you can remember it. Okay. Chalo. And the last question, A TB patient is showing resistance to isoniazid, rifampicin, then kanamycin and ciprofloxacin. Yes, very good, Siva. Mannitol is osmotic diuretic. Yes, right. So what you can see here, the resistance, here we can see it is isoniazid, rifampicin. Okay. Apart from that, kanamycin and ciprofloxacin. Now here you can see, yes, Siva, absolutely right. This is extensively drug resistance, which is also known as XDR. Now here we can see the resistance is not only to isoniazid and rifampicin, which is first line drug, then this is injectable drug, and this is fluoroquinolones. So if you have this much big picture, this is extensive drug resistance. And yes, if it is only this much, then you can say it is multi-drug resistance, right? So this is the concept of MDR and XDR in tubercular therapy. Isoniazid, rifampicin, only MDR, plus injectable antitubercular like kanamycin or any member of fluoroquinolones, you will call it, all the four you will call it XDR. Only two you will call it MDR. Clear? So MDR, isoniazid, rifampicin, and if you add two more in the second line anti-tubercular drugs, it will become XDR, that is extensively drug resistance, right? So this is enough for this session. Next subject will be PSM, but I think you must have enjoyed the session. So keep on studying. God bless. Bye bye. Good night.